Hello again, everybody. We're about ready to get started on a root canal tooth number 19. You'll notice that we've got the dam on and we've got caulking agents. You're going to notice the caulking agent is awful sloppy, awful ugly. And yes, I wish it looked better, but it doesn't really matter. We did a split dam on this. I wanted to make sure that there was no leakage, there was no contamination. In fact, maybe I should spend a few minutes talking about caulking agents. When we perform root canal therapy, one of the most important steps, though sometimes overlooked, is ensuring true isolation. The rubber dam, it's our gold standard for sure, but the reality is that even the best placed dam often leaves some tiny gaps around the clamp or even the surgical margin. Those micro gaps, they allow saliva, blood, or irrigants like sodium hypochlorite to seep into the operative field. Once that happens, our disinfection and long-term success rates can be compromised. That's why we use caulking agents. A caulking agent, it's simply a material placed around the clamp and the dam margins to seal those gaps and to prevent contaminations. You can think of it kind of like an insurance policy. It's my backup. Without it, even some perfect instrumentation and irrigation can be undone by leakage. If the patient tastes it, it's an awful experience. Or if saliva with any sort of bacterial component gets in there, it'll contaminate everything I've done. Now, there are different types of caulking agents. You can use a temporary restorative material like Cavit or IRM. They're inexpensive, they're easy to place, but I don't like them because they become brittle, and they're tricky sometimes to adapt to an irregular contour. You can also use a glass ionomer. These bond chemically, sometimes to the tooth, and they're strong and they're effective, but it's usually overkill and really expensive, quick way to do a seal. There are specialized caulking pastes. They're modern products that are incredible at this. Ultradent is the leader in this space, and that's the product that I use. They've designed a purpose-built material specifically for rubber dam sealing. Oraseal, which I use, it's hydrophilic. It's a syringeable paste that works beautifully in a wet field. It doesn't need any light cure, and it adapts really well even when moisture control is difficult. It's the go-to whenever I do a root canal and I'm dealing with any sort of challenging anatomy or even heavy saliva. You can tell though sometimes it looks a little sloppy. I don't really care as long as there's a good seal. There's some other ones like Opal Dam. It's light cured. It's a resin barrier, dispenses easily. It polymerizes into a flexible but a strong seal. It's commonly used for gingival protection and bleaching, but in root canals it provides an excellent barrier against leakage. It's a little more expensive than the Ultradent product, Oraseal, but it still is amazing. There's another one called Cool Dam. It's also light cured. It's a resin barrier similar to Opal Dam, but formulated to stay slightly more rubbery, which is good, and it's really flexible. This makes it ideal for sealing around clamps during root canal therapy since it's resistant to cracking or chipping. But again, it's a little more expensive, and so since it does the same job, I usually stick with Ultradent. It's very flexible, and again, that when I'm dealing with a large amount like this, that Ultradent product just seals amazingly. So how do we decide which to use? I would stay away from any sort of temporary material. They become too brittle. I would stick with either the Ultradent product or the resin-cooled ones like Cool Dam or Opal Dam. But in short, caulking agents serve one critical function. They preserve asepsis. Even with ideal canal cleaning and shaping, if saliva penetrates during treatment, you lose control of the microbial environment. By selecting the right caulking agent, you You simply save yourself a lot of headache in the future. You protect your field, you maintain sterility, and you increase the long-term predictability of the root canal. So remember, the dam isolates the tooth, but the caulking agent is what perfects the seal, and that seal is what ultimately protects the success of your treatment. Let's catch you up on what I'm doing right now. You'll notice I've made the access. We've identified the canals. We've used ultrasonics to enlarge the access. And now I'm using my rotary files. Each one is this currently right now is a 1504 edge file. And then I'll alternate that between the 15 and the 2004 rotary. Now remember, I always pre-measure my root canals with a CBCT. I already have an idea how long the tooth is. I want to make sure I stay short of that by about 1 millimeter or 2. And I use those instruments to that length. It makes it a little easier. The edge endo files in this case are incredible at navigating those canals, even the very smallest and tightest. Again, I'm using the ultrasonic to clean things out a little bit. And it does an amazing job. You'll notice that I'm always irrigating. I want to keep that tip nice and cool. This is super important. We're going to rinse it out, and then I'm going to talk about something though that you've noticed that I don't use. I don't use any sort of root canal lubricant, but I do want to talk about why lubricants are good. So I'm going to go on kind of a monologue again for just a little bit. The purpose of a root canal lubricant is it reduces friction. Resistance between the instrument and the dentin, lowering the risk of file separation, which is great. It aids in debris removal. It helps suspend and flush out any sort of dentin chips or pulp remnants. It also, remember, has a chelating agent in it. Usually it has EDTA, and this kind of softens the dental walls. This helps remove the smear layer and soften the calcified dentin, making negotiation of the cows a little easier, and it enhances the penetration of our sodium hypochlorite. By cleaning the smear layer, it allows the sodium hypochlorite and other irrigants to penetrate the tubules more effectively. Advantages: increases instrumentation safety. There's less torsional stress, reduced risk of breaking a file, increased cleaning. The effervescence helps dislodge any sort of debris. Better irrigant synergy, especially with sodium hypochlorite. It leads to enhanced antimicrobial action. Limitations: the residual paste may remain in the canal if it's not properly flushed. Another limitation that you'll hear people say, if it's overused, the chelators, EDTA, may cause excessive dentin demineralization. I call bullcrap on this one. You're removing microns with a chelating agent, yet with our files, we're removing much more than that. So you're going to hear that about using chelating agents like EDTA or even sort of lubricants that we use. I would just say that that's a textbook answer, but in reality, it doesn't matter. The other, you must always follow up with irrigation of sodium hypochlorite and even an EDTA rinse with the liquid form. So those are all the limitations and the advantages of it. So how do you use it? Because you're not going to see me use it. Is you're going to place a small amount of the lubricant on the canal or the file before instrumentation. Use it during the initial scouting and glide path preparation. Rinse thoroughly with sodium hypochlorite after each instrument to flush out the debris and avoid any sort of buildup. So the question is, why don't I use it? I don't use it because it is awful at obstructing the view of my canal. I want to be able to see every single canal. I want to make sure that I'm in every canal. And I find lubricants annoying at obstructing the visualization of the canals that I am trying to clean and shape. Now, I will say, using sodium hypochlorite as my lubricant, which I do, it's not truly a lubricant. Sodium hypochlorite doesn't help decrease the friction. It is a fluid, and I'm sure it decreases it somewhat. But in reality, I don't know any sort of study that tests this, but it has not near the lubricant qualities that many of these lubricants in the field do. Also, using sodium hypochlorite as a lubricant can be somewhat dangerous. If I push a file too fast or too hard, I may actually push sodium hypochlorite out the apex. So you may notice I try to go really slow with my files. I don't pump them up and down quickly. It may appear sometimes in the video that I do. That might be because I'm actually speeding up the video to not bore you as much as possible. But I do not use any sort of lubricant that is thick and viscous, because I cannot see the canals, and visualization to me far outweighs any sort of advantages that the lubricants do. Now, to catch us up again with the root canal, you'll notice that we've cleaned and shaped. We have spent a little time already finding the length of the distal buccal, distal lingual canals. Now, right now, I am actually measuring the mesial canals. I'm using a 10-hand file. I'd like to remind you, you will hear the larger the file, the more accurate the measurement. Again, that is not accurate. What is the case is the more canal touching the file, the more accurate. So find a file that is snug. If it requires a 10 and it's snug, you're going to get a great measurement. If it's a 15 or a 20, 25, sometimes the anterior canals are ginormous. And if you're going to use a 10 or 15, you're going to get a very inaccurate reading. The larger the file does not affect the measurement accuracy. The snugger the file, it does increase the effective measuring and accuracy of the apex locator. That's probably enough of the apex locator. We're going to begin doing the cleaning and shaping. This is the bulk of the root canal. Traditionally, there's always been what's called the crown down approach, which means we start big and coronal and then gradually work smaller as we move toward the apex. I do not do a crown down approach necessarily. I do what's called a modified crown down approach. But let me talk just a little bit more about the traditional crown down. In a traditional crown down approach, we enlarge the top of the canal first, then the middle, and only at the end do we approach the apical third. This gives us a straight access, it removes interferences, and it actually improves irrigation from what they used to do with hand filing. Now, the modified crown down method makes one important adjustment. Instead of finishing all of the coronal preparation before ever touching the apical third, we alternate between coronal flaring and apical advancement. Think of it as a stepwise kind of a dance down, then up, then down again. Each move balancing the next. So kind of here's how it works. I start with the coronal flare using my ultrasonics. Some people use orifice openers or large rotary files. That opens the top and the middle third. Next, we negotiate with the canal. We negotiate the canal with a small hand file, maybe a 10, 15K file, just to working length. That establishes the glide path. Once that small file reaches full length, we turn and enlarge the coronal portion again with a slightly larger instrument. After that, we go deeper again with a smaller file. Then flare coronally once more. We repeat the sequence, altering back and forth until we've shaped the entire canal smoothly from crown to apex. Why does this modification matter? It reduces stress on our instruments for one. We don't want to break a canal or a file in the canal, especially those that are very curved. But also progressively removing coronal restrictions as we go, each apical file meets less resistance and we don't break as many files. It also keeps debris moving coronally rather than compacting apically, and improves irrigant penetration to the apical third throughout the process. Rotary instruments are fantastic because they pull debris up. A lot of hand filing actually pushes debris apically. So the rotary instruments have increased our ability to remove debris coronally, which is fabulous, but then you add the modified crown down method and you get less apical packing of debris. In short, though, the modified crown down method, it's all about balance. Instead of racing straight to the apex or clearing the coronal entirely before moving down, we alternate, enlarging, negotiating, until the canal is clean, tapered, and ready for obturation. That's why many clinicians find the modified crown down approach safer, smoother, more predictable than the classic crown down method. Now, I've already talked about using a lubricant and the fact that I don't use one. I use sodium hypochlorite as my lubricant. And you're going to see lots of irrigation with sodium hypochlorite. In between almost every single canal use of, or cleaning of a file down a canal, you're going to see I'm irrigating with sodium hypochlorite. Here we go again. Let's talk about sodium hypochlorite. During the videos, I sometimes speed up the use of the sodium hypochlorite because it's kind of boring. But I do want to spend a few minutes talking about why it's the workhorse irrigant in endodontics. Now, why do we reach for it almost universally? Simply put, and this sounds cheesy, it does two things no other irrigant does as well. First, it kills microbes. Second, it dissolves organic tissue. Those two properties make it indispensable in root canal treatment. When we introduce sodium hypochlorite into the canal, it reacts with organic matter, the pulp tissue, the pulp remnants, necrotic tissue, even the bacterial biofilms. The process of interaction is called chloramination. It breaks proteins down into their amino acids. Basically, it liquefies the tissue so it can be flushed away. At the same time, it has an oxidizing action. It destroys microbial cell walls. It inactivates essential enzymes. That's why it's so powerful at being an antimicrobial. But this same strength, it's also its greatest weakness. Sodium hypochlorite doesn't know the difference between infected pulp tissue inside a canal and healthy connective tissue beyond the apex. If any of it is extruded into the periapical tissue, it causes immediate chemical injury and immense pain. The tissue necrosis, there's swelling, there's bruising, and again, I want to emphasize, there is severe pain. This is what's called the infamous sodium hypochlorite accident that every dentist, every endodontist dreads. So, is there anything better out there? Well, we have some alternatives. Chlorhexidine, it's a great antimicrobial, but it doesn't dissolve tissue. There's MTAD and Quick Mix. They combine antibacterial action with smear layer removal. But again, they lack strong tissue dissolution. Even newer ideas like ozonated water, hypochlorous acid, and nanoparticles, they show promise, but nothing has matched yet the complete profile of sodium hypochlorite. That's why for now, sodium hypochlorite remains the gold standard. The real emphasis in modern endodontics isn't about replacing it, but about delivering it safely and effectively. This means using side-vented needles, negative pressure systems like the Endovac, ultrasonic, sonic activation to maximize cleaning inside the canal while minimizing risk outside the apex. Now you'll notice I don't use a side venting needle. I use an end venting needle, which means I need to be extra careful. I want to make sure I stay about 2 millimeters away from any sort of apex. So the take-home message is this. Sodium hypochlorite is both our best friend in root canals and it's also our potential enemy. Respect its power when you use it. Use it wisely. Always combine it with EDTA for smear layer removal, and you're going to achieve disinfection and cleanliness that root canal success depends on. We're nearing the end of the root canal. You're going to notice I'm using what's called the XP3D finisher file. I'd love to spend more time talking about this file, but I'm just going to spend just a few minutes. I love the Brasseler's shaping and finishing file. Now I'm not going to go into too much detail about it, but this is the finishing file. I use it to help stir up the sodium hypochlorite and the EDTA. I run it at approximately 2000 to 2200 RPM. It helps stir that irrigant up, whether it is sodium hypochlorite or EDTA, and I use it in every single one of my canals. I'm speeding things up, but I use it for about 20 to 30 seconds in each canal. I find it very effective at removing any sort of debris. In fact, when I do retreatment sometimes, I'll use it and I'll be able to bring up little pieces of gutta percha that I didn't see and I didn't think were there, which often leads me to go back, do a little more filing with the traditional files, and then using it again. I love the finishing file. I love how much debris it brings up. At this point, you're going to see that I'm going to try the cones in. I have shaped this one to a 45-04 taper. That's the distal lingual canal. Now I'm trying in the distal buccal. We're going to gently place that in there, get a little tug back. I'm going to measure it, pull it back, bring it to my mirror handle, measure it, make sure it's measuring at the appropriate length. Once I do that, I change. Now I'm going to go to the mesiolingual. I'm placing it, making sure there's a little tug back, taking it again to my mirror, measuring it, putting it aside, measuring another one. You're going to see me bring in another 30-04 cone. We're going to go into the mesial buccal, place it in there, get a little tug back on that. There we go, measuring it. Now I've got all of my cones fitted to the appropriate length. I'm going to irrigate some more. This is sodium hypochlorite. I want to make sure I do a thorough flush with sodium hypochlorite. We're going to speed this up. Again, I do not go to length with my irrigation. I use an open tip, which again, if you're a dental student, I do not recommend. I would use a side venting needle. I do stay away from the apical exit of the canal by about 2.5 millimeters. And there's some great studies that show the push of sodium hypochlorite past the irrigating tip I can go into some detail on those in another video, but staying 2.5 millimeters is safe when using an end venting needle. I'm going to go back through, making sure that I've got good patency on everything. This is the boring part. You'll notice I used my 20 and 15 in a very robust way. I go through perhaps maybe sometimes one, sometimes up to 4 different sets of 20 and 15. They are my workhorse files. We've gotten good length. We've recapitulated. We're going to irrigate some more. We're getting really close to the end of the root canal. We're going to spend a fair amount of time irrigating the canals. We've talked about sodium hypochlorite. You know why we do it. What happens next after I do all of my irrigating is I dry the canals. Let's talk about drying the canals before completing the root canal and why it's so critical. Think of a canal space kind of like a battlefield. We've just spent a lot of time irrigating and disinfecting, trying to eliminate bacteria, necrotic tissue, and any other toxin. If we leave moisture behind, we're essentially leaving behind a safe harbor where bacteria can hide, survive, and recolonize. A wet canal is a biologically risky canal. But biology isn't the only reason. We also have to think about the materials we use. Our sealers and our gutta percha are designed to flow, adapt, and seal in a relatively dry environment. Too much moisture interferes with how they bond or set. Resin-based sealers, which a lot of people don't use, but some do still, may not polymerize correctly. Zinc oxide eugenol sealers, again, people don't use those a lot, but they can wash out. And even bioceramic sealers, which are the most used sealer today, though they like a hint of moisture, they cannot perform well in a flooded canal. If the environment is not properly controlled, we'll end up with voids, gaps, or a weak seal. Here's the bottom line. The entire long-term success of our root canal treatment depends on that apical and coronal seal. A properly dried canal prevents leakage, reduces post-operative pain, and greatly increases the chances that the tooth will remain symptom-free and functional, hopefully, for years to come. So when we dry, we're not just removing water or sodium hypochlorite or EDTA or even blood. We're setting the stage for everything else to succeed. A dry canal means fewer bacteria, better sealer chemistry, and a long-lasting seal. That's why drying is one of the most important finishing steps in endodontics. Seems like every single step is important in endodontics. Feels like every little detail really matters. Now you're going to notice that when I place these paper points into the canal, I do not plunge them in quickly or fast. I go slow. If you drop that paper point too quickly into the canal, you have a high likelihood that you may actually push sodium hypochlorite past the apex into that tissue, causing a small sodium hypochlorite accident. Patients don't like it. In fact, you may, if you do it too quickly, they'll go, oh, I kind of felt that. And then they're going to be the ones that call you later that night or 2 to 3 days later saying that tooth just hurts so bad. That happens even when you don't push sodium hypochlorite past the apex, but it really happens when you do. Now we're getting ready. It looks like the canals are nice and dry. We're getting ready to place sealer. You're going to notice I'm placing the sealer in each one of the canals. When you look back at the history of sealers in endodontics, kind of a story of trial and error. of figuring out how to fill that last microscopic space that gutta percha just can't occupy. We started with some zinc oxide eugenol sealers. Now, I've got one of those in my mouth. Got it when I was 8 years old. I still have it 40 some odd years later. But they had some downsides. They had some upsides. They were simple. They were cheap. They had eugenol, which was great at being antibacterial. The problem was they dissolved over time. Over time, they would literally wash out. They would leave voids. They also had issue with discoloration. My tooth is completely black. And they weren't particularly friendly to tissue if they were extruded past the apex. They worked for a while, but we know that there had to be better solutions. Some people still actually use it. That's when resin-based sealers stepped in. There's an epoxy resin that came out called AH26, later called AH+. Used to love this sealer. It became our gold standard for a long time. Gave us a nice tight seal. It was less soluble. It looked great in an x-ray. It had great radiopacity. For many of us, this was the sealer we trained on and really loved. But it came with some baggage. Cytotoxicity. While setting, it took a long time to set. It was difficult when retreating just because you couldn't get it all out. And there was some significant shrinkage. They filled the space, but they didn't do anything more than that. And they weren't inert passengers in the root canal. The real shift happened when bioceramic sealers came into the scene. These are calcium silicate-based materials, cousins of MTA, mineral trioxide aggregate, and they don't just sit there. They're bioactive. When they come in contact with moisture in the dentin, they release calcium hydroxide. It raises the pH and start forming hydroxyapatite. That hydroxyapatite chemically bonds to dentin, giving us not just a mechanical fill, but a biological integration. Suddenly, the sealer wasn't just sealing, it was interacting with the tooth, encouraging tissue healing and even stimulating hard tissue formation at the apex. Another thing that makes them unique is their hydrophility. They love water. Traditional sealers hated moisture. Any residual dampness could compromise the set. Bioceramics actually wanted it. They thrive in the environment of the root canal where they can't get rid of every last molecule of water. On top of that, they're dimensionally stable instead of shrinking like resins. They actually expand just a bit, closing micro gaps, combining with their high biocompatibility, and you've got a material that the apical tissue tolerate or even welcome. The problem is they don't look as good in an x-ray. They're not as dense. The practical benefits, though, you can do simplified obturation techniques like the single cone method, which I use, which then paired with hydraulic sealer like this actually works. They seal tightly, promote healing, and reduce micro leakage. The downside is, again, retreatability. These things bond hard to dentin, so getting them out can be a wrestling match. And you're going to see it in a couple of the cases I have coming up where I'm doing retreatments. So what does all of this mean for endodontic success? Well, if the goal is to disinfect, seal, and allow healing, bioceramic sealers line up with all three. Their antimicrobial activity during setting helps mop up what irrigants and medicaments didn't. Their expansion and bonding kind of mean a long-term seal. And their bioactivity means the body actually responds favorably, laying down new hard tissue and repairing periapical damage. They move us closer to the idea that endodontics isn't just about filling a space, it's about creating a biologically active environment that favors healing. In short, sealers have gone from temporary fillers to inert space pluggers to biologically integrated materials that participate in the healing process, and that's a huge evolution in the success and the predictability of endodontics. Now we're pretty much done with the root canal. We're going to clean things up, and then we're going to place a filling. At work, I often get asked, do root canals really work? The numbers are actually really encouraging. Multiple long-term studies show that root canal success rates are anywhere between 85 to 97%. Kind of depends on how success is defined, but if you're looking for a tooth that's symptom-free, it's functional, radiographically healed at 5 to 10 years, that's where those numbers fall. Even at 20 years out, survival rates for teeth that were properly treated and properly restored, they're still above 80%. That means when it's done right, a root canal is one of the most reliable treatments in dentistry. But here's the key. Root canal success is a two-step dance. Step one is the endodontics. Disinfecting, shaping, and sealing. Step two is the restoration. Protecting the tooth against reinfection and against fracture. If you only do the first step and ignore the second, you're setting the tooth up for failure. This patient came to me. They had a newly placed composite restoration, placed within the last couple weeks. Irreversible pulpitis, then necrosis. We've done the root canal. So here's what happens next. After the canals are filled, we place a coronal restoration. This might start as a bonded composite, or like we're doing here, or it might be bigger, a core build-up. That serves as the immediate barrier to bacteria and to keep bacteria and saliva out. The quality of that seal is critical. Leakage can undo a perfectly done root canal in a matter of weeks. Then, depending on how much natural structure is left, the tooth almost always needs a crown, especially if it's a premolar or a molar. I'm going to actually change that. Always when there's a premolar or a molar. The reasons. First, strength. Root canal treated teeth have lost some internal dentin and often have large access cavities or caries removal. So their cusps are weakened. Without coverage, they're prone to split right down the middle. A crown helps brace the cusps together like a band around a barrel, preventing catastrophic fractures. Second, sealing. A crown provides a long-term, stable control barrier that dramatically reduces leakage compared to fillings only. So the process. Canals are sealed. Filling or core buildup is placed, often with composite, sometimes an amalgam. If a lot of structure is missing, sometimes a post is placed, but I despise posts, so we place them as often as possible. The tooth is then prepared for a crown. An impression or scan is taken, and a temporary crown or immediate crown, same day, is placed. Studies show that teeth that receive crowns after root canals are up to 6 times more likely to survive long term than those left without crowns. That's not a subtle difference. It's night and day. So, is the crown optional? The answer is no, it's not. It's part of the treatment plan. When you zoom out, the picture is this. Root canal therapy is incredibly successful, but only if it's paired with a strong, well-sealed restoration, and it's usually anterior teeth can get away without a crown, but if it's a molar or premolar, the crown is always part of the treatment. You could do most textbook endo in the world, but without that coronal protection, you've only done half the job. The success comes from the combination: a clean and sealed root canal system and a strong protecting crown above. Together, that's what gives us the high survival numbers and keeps that tooth in the mouth, hopefully, for decades. Now, we've missed some of this. I've started the placement of the restoration, but I'd like to kind of go back just a little bit. You missed it. I've etched it. When we're placing a restoration, the key challenge is composite resin doesn't naturally bond to tooth structure. That's where the bonding agent comes in. After etching, we create a surface full of microscopic porosities. The bonding resin flows into those spaces. Once cured, forms resin tags that mechanically lock the composite into the enamel. That's why enamel bonding is so strong and predictable. Dentin's trickier. It's hydrated, so it's got tubules, and it's organic matrix that doesn't bond as easily. When we etch the dentin, we remove the smear layer and expose the collagen framework. The primer and adhesive soak into the collagen, and when they cure, they form what we call a hybrid layer. That hybrid layer is both mechanical and chemical. It's the real bridge that connects the composite to the dentin. Without it, you have leakage, sensitivity, and a restoration that, well, no sensitivity in root canals, but you can. It simply won't last. Now, in an endodontic access, after completing a root canal, we need to build the tooth up. So it's got a coronal foundation. This is where a dual cured flowable core like I use here is excellent. It's flowable. It adapts easily to the irregular shapes of the access cavity. Surrounding the canal orifice and filling smaller undercuts, it gives you a kind of an intimate adaptation, and it eliminates a whole lot of voids. The dual cure that I also use is the second advantage. Deep inside the pulp chamber, the curing light doesn't always penetrate completely. If you're relying on the light alone, you'd risk the areas of uncured resin. But the dual cure systems polymerize chemically as well. Kind of completes the set throughout the entire buildup. Once cured, the material, it's rigid, strong, and it's ready to serve as the foundation for that crown we were just talking about. So now that we're done with the root canal and we've placed the restoration, we're ready to have this patient go back to their dentist and get a full coverage restoration on that. As I adjust the bite, I want to make sure that this tooth is out of occlusion, both in its natural centric bite and its lateral extrusions. I take a fine grit diamond burr, removing any sort of sharp edges along the cusps, moving anything that might come in contact. We're going to remove the rubber dam. This is the favorite part of every patient. Take that damn thing out of their mouth. We're going to have some caulking still around that tooth. We're going to take our ultrasonic. We're going to clean up around it. Now you're going to notice on his tongue he's got a small ulceration. I wish I'd addressed it before, but prior to treatment he had an ulcer there as well. He had placed some medicine in that area, an aspirin, to kind of try and help heal it. He and I talked about that aspirin should not be placed next to the tooth, the gum tissues or anything like that. So he's got that ulcer. You'll see it there on the tongue. We addressed it. We told him about it. Told him it would go away in about 7 to 10 days. There I am pointing out to you. Doesn't look that pleasant. Now we're done. Thank you.